Okay. Hello and a very good evening, everyone. Ma'am, you can turn your camera on. Yes. Very good evening, everyone. We are starting with day 2 of International Academy for Medical Students, and I welcome you all on behalf of ClinCase. First of all, a very happy Independence Day to each and everyone present here and watching us on YouTube. So I'd like to introduce myself. Abhilash Singh. I'm a third year MBBS student from BKL Valvalkar Rural Medical College, and I'm also the senior executive of academic wing at ClinCase. Today, we are here with our day 2, which is case presentation competition. We have 7 case presenters with us, and they'll be presenting the case. And we have 2 judges with us, Dr. Uday Tambe and Dr. Mamta Patil. Dr. Uday Tambe, he's the HOD for surgery at BKLWRMC, Ratnagiri, and Dr. Mamta Patil, she's professor of medicine at RRMCH, Bangalore. So we'll start with our basic instructions. So yes, Vinay, you are here. You have 10 minutes to present your case. Okay. And next 5 to 7 minutes will be followed by question.
Abhilash, there is issue with audio.
I got disconnected or something happened. Okay, so Vinay, you have 10 minutes for your presentation, and then we have 5 to 7 minutes for questions. And questions will be asked after your presentation is over. I will interrupt you at 2 points, one after 5 minutes and one after 9 minutes. As soon as 5 minutes gets over and as soon as 9 minutes gets over. Is that clear with you?
Yes, okay.
Okay. And you may start with your introduction as soon as you Hello, Vinay.
Yes.
So go ahead.
Okay. A very good afternoon to one and all present here. I'm Vinay Suresh, currently in my second year of MBBS in King George's Medical University, Lucknow. I'm extremely grateful to have been given this opportunity by ClinCase SN to present my case on tuberculous spine at the International Academy for Medical Students. So I'll begin by history taking. A 34-year-old male cab driver came into our clinic. He was illiterate and had low socioeconomic background. He walked in with chief complaints of back pain, which lasted about a month, leg pain since 2 weeks, and inability to drive his vehicle since a week. He had pain in the lower back region that was insidious in onset. It was an initial low-grade dull ache that gradually progressed to severe grade and radiated to the right leg. It was aggravated with movements. There were complaints that included difficulty to drive, stand, and walk around due to pain. We also observed that the pain reduced marginally in supine position. The leg pain was moderate to severe in right leg, present throughout the day, and it was also aggravated with movements. Coming to negative history, there was no history of leg weakness, numbness or tingling in the lower limbs, bowel or bladder disturbances, no pain in the neck or upper limbs, no joint pain or stiffness, no weakness, numbness or tingling in the upper limbs, no history of trauma, no history of fever or cough, and no history of loss of appetite or weight loss. Coming to personal history, our patient was a non-smoker, he was a non-alcoholic, and he had no history of drug abuse. His past history had no history of headache, backache, or neck pain in the past, no history of weakness in upper and lower limbs, and no past history of trauma. Basically, his past history was unremarkable. Coming to the medical history, he was a non-diabetic, he was non-hypertensive, he had no cardiac ailments, he had no thyroid disturbances. And there were no history of suggestive of connective tissue disorders, and he had no history of surgery in the past. Coming to drug history, he was prescribed analgesics for the pain relief, such as diclofenac and paracetamol. He was not on any other medications. Coming to family history, there was no family history of connective tissue disorders. There was no family history of tuberculosis or any such similar problems in the family. Now, summarizing the history, the patient's chief complaint was persistent progressive back pain, which gradually radiated to the right leg. There was restricted motor functioning in activities like driving and walking. Personal, past, family, and negative histories all indicate no apparent involvement of any direct causative factor. Coming over to the examination, he performed the general routine physical examination. He was a young male. He was moderately built and nourished. His overall general condition was fair. He was conscious, alert, and cooperative. No pallor, no icterus, no cyanosis, and no clubbing. No lymphadenopathy was observed. He had, however, difficulty to stand, walk, and bend forwards due to pain. His vitals were mostly normal. His pulse rate was 70 beats per minute. His BP was 130 by 80 mmHg, which is well within the normal range. And the temperature was afebrile. On local examination, on inspection of the lower back, we found no swelling or mass, no scar also was seen, no changes in skin color or texture, no changes in curvature of the spine, and no obvious bone deformity of the spine. On palpation, there was tenderness over the lower lumbar spinous process, no local raise in temperature, and no mass was felt. For lowering examination, we performed the straight leg rising test, where the patient was able to rise his right leg up to 45 degrees and 60 degrees in his left leg. On motor examination, the muscle bulk was normal and equal bilaterally. The muscle tone was also normal on both the sides. The muscle power was 5 by 5 in all groups of muscles of both lower limbs. Coming to motor reflexes, the deep tendon reflexes, knee jerk and ankle jerk was normal in both the lower limbs. The plantar reflex was flexor bilaterally. And on performing the sensory examination, we found that his touch, pain, temperature, and vibration sensations were all normal in all dermatomes of both the lower limbs. And perianal sensations were normal, indicating that the S2, S3, S4 spinal segments were functionally normal. And during the upper limb examination, the motor, sensory, deep tendon reflexes were normal on both the sides, and abdominal reflexes were also normal. So then we went ahead with systemic examination. His higher mental functions were normal. The cranial nerves were normal. There were no meningeal signs such as the Koenig's or the Brzezinski's sign. And in serious examination, we found we could hear the S1 and S2 heart sounds, and there were no murmurs. In respiratory system examination, the patient had normal breath sounds, and no rhonchi or crepitations were heard. Her abdominal examinations were soft and tender with non-tender with no organomegaly and normal bowel sounds. So after taking a comprehensive clinical history of the patient, we came to the following differential diagnosis, that is intervertebral disc prolapse, paraspinal muscle sprain, or lumbar spondylodiscitis. Now, the reason why we suspected these conditions is because the patient was a cab driver who are usually prone to spine-related problems due to bumpy roads and incorrect posture for prolonged periods of time. Now, keeping these conditions in mind, we went for the following investigations. The complete blood count or the CBC test, the ESR levels, and the C-reactive protein. All the stats such as the RBC count, hemoglobin, and TLC were found to be normal. However, we observed significant rise in ESR and marginal rise in CRP levels, which is clearly suggestive of an infective or inflammatory pathology. Other blood investigations such as the blood urea, creatinine, sodium, and potassium levels were all well within normal range, and he was HIV negative. Now, coming to the radiological test, the chest X-ray of the patient was normal. However, the contrast-enhanced MRI of the lumbar spine in sagittal view showed reduced disc space between the L3 and L4, with altered signal intensities along with involvement of adjacent vertebral surfaces. The CT scan of the lower lumbar spine was done. It showed bony involvement adjacent to the disc space. And on microscopic examination of the CT-guided biopsy, we observed that there were randomly distributed epithelioid cells along with few lymphocytes. There was no evidence of any malignancy, and features were suggestive of granulomatous inflammation, most probably because of tuberculous pathology. So our diagnosis was spondylodiscitis of L3, L4 without any neural involvement, most probably due to tuberculosis, as was suggestive of the investigations.
5 minutes over.
Coming to treatment, an important point to be noted here is that we assessed liver function via LFT prior to giving antitubercular drugs, as they are considered to be hepatotoxic. So LFT was also found to be normal, which indicated no signs of any liver damage. We started the anti-tubercular therapy with the first-line drugs, including isoniazid, rifampicin, ethambutol, and pyrazinamide for 4 months. This was followed by two drugs, that is rifampicin and isoniazid, for the remaining 14 months. Pyridoxine supplementation was also given, and analgesics were given for relief in pain. Normal diet was prescribed and bed rest was advised. Now, coming to advice at follow-up, we advise strict compliance with regard to the anti-tubercular therapy, and bed rest to be continued till pain-free movements, and regular follow-up, which was tailored to the patient's response according to treatment. And repeated blood tests was recommended, CBC, ESR, and LFT to be done. Repeated X-rays, LS spine scan to be done to look for resolution and progression with the resultant bony changes. And upon follow-up, we found that in 1 month, there was regression in backache, there was decrease in severity of pain, CBC and LFT were found to be normal, and ESR was decreased. In 3 months, the patient could perform routine daily activities. There was significant reduction in pain. The CBC and LFT were normal, and ESR levels were normal. X-ray was also done, and in 6 months follow-up, the patient resumed all activities without any pain, and X-ray was done again. This was the 6-month follow-up X-ray, the AP and lateral view, and we can see good bony fusion without any bony deformities. So to conclude, extrapulmonary tuberculosis can be deceptive in its evolution and presentation. Spine is the commonest site of involvement in these cases, and proper diagnosis and initiation of early medical treatment in tubercular spondylodiscitis is necessary to avoid permanent bony deformities such as kyphosis, scoliosis, or gibbus, and spinal instability, and also to prevent neurological deficits such as limb weakness or mono or hemiparesis, as well as other neurological deficits. Thank you.
Hello.
Hello, sir.
Hello.
Good afternoon, sir.
Yeah, Vinay. Vinay.
Yes, sir.
Hello.
Yes,
Vinay,
sir,
can you
sir.
hear me?
Yes, sir.
Can you hear me?
Yes, sir. I can hear you.
At the start of your investigations of the patient, did you, before doing CT scan, you did is plain X-ray or not? Plain X-ray of spine.
Yes, sir. Chest X-ray.
Did you consider that? Because you have not shown.
I haven't shown.
Spine X-ray. Spine plain X-ray.
No, sir. We didn't go for spine X-ray. We didn't go only chest X-ray.
Why you did not do that?
Sir, we thought that MRI would be more conclusive and it would show.
That's okay. That MRI, of course, that is better than, but still at initial stage, just to screen out the other possibilities.
Actually, yes, sir.
Okay.
Yes. Sir.
You are not done it. Okay.
No.
Okay. Fine. And at any point of moment, did you think of any multi-drug resistance tuberculosis in this case?
Yes,
so
actually.
Did you try to?
Right, sir.
Yes.
Yes, sir. We did think of it. Actually, after giving first-line drugs, we waited to see how he'll improve. After 1 month follow-up, there was significant reduction in pain. So we concluded that there's no resistance in any antibiotics. If there was, so we could have proceeded to any second-line drugs like moxifloxacin or amikacin.
Okay, fine.
Hello.
Hello,
Vinay. Can you hear me?
Yes, ma'am.
Yeah. Suppose if this patient has a past history of pulmonary tuberculosis, in his future days, can he present with a spinal tuberculosis? If so, how?
Ma'am, yes, ma'am. Actually, spinal tuberculosis is possible because of hematogenous spread. It can occur mostly due to direct inoculation, and it can spread to the intervertebral space, and it can cause extrapulmonary complications.
Okay. Then in the local examination, which bony vertebral tendons was there? Which lumbar vertebrae?
L3 and L4, ma'am. L3 and L4 was involved.
He had local tenderness was there?
Local tenderness was observed, ma'am, but there was no increase in local temperature, and only tenderness was observed, ma'am.
Okay. Then what about the SLR test you did, no?
Straight leg rising test.
Yeah. What it suggests to you?
It was normal, I think. It was normal.
It was normal.
No, 45 degrees, 60 degree rated, no?
Yes, ma'am. So the right leg showed weakness because of pain. He was not able to raise it completely.
You consider it as a positive or negative SLR test?
Yes, ma'am. It was positive for the right leg. He couldn't raise it up to 60 degrees, and which suggested that there was a pathology.
Okay. What is the name for that? Any other names are there for SLR test?
No, I don't know. So,
Why you do the LFT, basic LFT level, if you want to know, before starting the AKT?
ma'am, we do it because most of the antitubercular drugs like rifampicin and isoniazid, they are hepatotoxic actually. So that's why we go for LFT, and then we assess the liver function, and after that we proceed to antitubercular drugs.
Okay. Suppose if you don't do the LFT, okay,
Yes,
then what happened to the LFT levels? Can you tell? If you know,
yes,
you
ma'am. LFT
answer.
levels were normal. The AST and
No, not in this patient. No, no.
Yes,
Suppose
ma'am.
if you don't do the LFT before starting the AKT,
Right.
okay. After starting AKT 1 or 2 weeks, you'll be getting the LFT derangements, means abnormal LFTs.
Yes, ma'am.
Okay. What levels will be this one? Whether the enzymes will be deranged or bilirubin will be deranged? What will be expecting?
Yes, ma'am. The enzymes will be deranged. ALT-AST will be deranged. There will be increase in ALT-AST levels, and it will indicate a progression to liver failure. And it shows inability of the liver to metabolize the drugs. So we'll shift to other drugs which are less hepatotoxic.
Okay. And last question. Yeah. Yes. What is the difference between kyphus and gibbous?
Kyphosis is
no, not kyphosis. No, not kyphosis. Kyphus and gibbous.
Gibbous is acute bending, ma'am. There's acute bending in case of gibbous.
Then kyphus?
Kyphus is just forward bending. In case of acute.
No, not kyphosis. I'm asking the kyphus.
Kyphus. I'm not sure.
Yeah, kyphus. Okay. Kyphosis is different. Kyphus and gibbous. Any difference is there?
I don't know about kyphus, ma'am.
Okay. And last question. What about the cold abscess?
Cold abscess, yes, ma'am. Actually, initially before the introduction of these antitubercular drugs, before there used to be a complication of cold abscess in the vertebral bodies, which used to also spread to the intraperitoneal and hematogenous spread. But now, because we have better antitubercular drugs, we don't see this as a complication nowadays.
Okay.
Vinay, one more question is there.
Yes.
What is the mechanism of this hepatotoxicity induced by this drug-induced hepatotoxicity, especially due to this AKT? What is the mechanism?
Sir, I'm not sure of the exact mechanism. Yes? I'm not sure of the exact mechanism, sir, but
okay. Fine.
Thank you, sir.
So much, Vinay. And you can leave the call.
Yes, sir.
Okay. Padmavati, you're there?
Hello, am I audible? And is my screen visible?
Yes, you're audible and you're visible.
Okay.
Okay. As soon as I say start with your introduction. After your introduction, your timer will start, and you can share your screen sharing right now only, so as to save some seconds.
Yeah, sure. Just a minute. Is my screen visible?
Yes, you are visible.
Yeah. No, is my slide visible?
Yeah. For me, it is visible.
Yeah.
Visible. Yes, it's visible.
Okay.
Start with the introduction.
So good evening to the judges and everyone present here. I am Padmavati Krishna Kumar. I am a third year medical student currently pursuing MBBS at Adi Chunchandgiri Institute of Medical Sciences, BG Nagara.
Yes, go on.
So I'm a third year medical student, and today I will be presenting a case on nasal polyp. Can I start presenting?
Yeah, you start.
Okay.
Yes, please go ahead.
So patient details, the name of the patient here is Mr. X. Here's a patient named Mr. X who's 30 years old and is a farmer by occupation from Bellur in Mandya district. His socioeconomic status as per the modified Kupuswamy scale is upper lower class. His chief complaints are bilateral nasal obstruction since 3 years. History of presenting illness. A patient developed watery nasal discharge, excessive sneezing, and redness in eyes 4 years back, which wasn't on exposure to dust and early in the morning. He was prescribed steroid nasal spray for the same. And patient, after which patient developed nasal obstruction 3 years back, insidious in onset, gradually progressive in nature, and partially obstructive. Initially, it was more on the left nostril, and it gradually progressed to the right. It wasn't early in the morning and on lying down, and was on relieved on taking either the nasal spray or extra nasal drops temporarily. It was associated with anosmia and also mouth breathing and snoring. Negative history, no history of headache, no history of postnasal drip, no history of epistaxis, no history of throat pain or sore throat, no history of ear complaints like diminished hearing or ear discharge, no history of fever and cough. Past history, patient is not a known case of diabetes, mellitus, asthma, hypertension, or TB. He has had no other chronic illnesses before, and there is no history of past ENT surgeries. There is no significant family history. Personal history, his diet is mixed, appetite normal, adequate sleep, bowel and bladder is normal, no ill habits. And this is a summary. After the history, Mr. X is a male patient aged 30 years, presented with complaints of bilateral nasal obstruction since 3 years, which was insidious in onset, gradually progressive, associated with anosmia, snoring, and mouth breathing. He is a known case of allergic rhinitis since 4 years and was on medication for the same. Differential diagnosis based on history, ethmoidal polyp, antroconal polyp, DNS with S-shaped deviation, hypertrophy of inferior turbinate with septal deviation. General physical examination. Here's a young male patient, moderately built and nourished, conscious and cooperative, who is well oriented to time, place, and person. No sign of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. His vitals are clinically normal. Systemic examination, cardiovascular system, S1, S2 heard, no murmurs. Respiratory system, normal vesicular breath sounds heard, no added sounds. Per abdomen examination, soft, non-tender, and no organomegaly. CNS findings intact and no focal neurological deficits. Local examination, we began with the examination of nose. External framework findings are normal. Vestibule, the cavity is normal. Anterior rhinoscopy findings, mucosa is congested on both sides. Inferior turbinate is normal on both sides. Septum is deviated slightly in the right and normal in the left. Nasal cavity findings show multiple pale, smooth, glistening polypoidal masses. Probe test, on probe testing, probe is passed all around except superiorlaterally. It is mobile, insensitive to touch, and does not bleed on both sides. Diagnostic nasal endoscopy findings. On both sides, we find multiple pale, polypoidal, smooth, glistening mass occupying nasal cavity and extending up to anterior border of inferior turbinate. In left side, however, it only extends up to the middle of inferior turbinate. Lund-Mackay grading of DNE is grade 2 on both sides. Functional tests, cold spatula, on both sides the findings are same. There's reduced misformation on cold spatula test, reduced movement of cotton wisp, no sensation on both sides on smell test. Cottles is negative in both. Paranasal sinuses, skin over maxillary, ethmoid, and frontal sinuses show no signs of redness or swelling. Sinuses are non-tender. Ear examination findings are normal. Functional assessment of ear is also found to be normal. Oral cavity examination and oropharynx findings are also normal. Neck examination, there was no lymphadenopathy and the findings were normal. Summary after examination. Mr. X is a male patient aged 30 years, presented with complaints of bilateral nasal obstruction for 3 years. He has had recurrent episodes of allergic rhinitis for 4 years and was on medication for the same. On examination, there is presence of multiple smooth, glossy, pale gray masses in the nasal cavity on both sides. On probe test conduction, these masses were movable, insensitive, mobile, and they don't bleed on touch. Provisional diagnosis is bilateral nasal polyp, which is likely ethmoidal. Investigations, we do a complete blood count. We do an absolute eosinophil count, bleeding and clotting time, complete urine examination.
5 minutes
and
over.
We do a X-ray of the periphery. Some deep breathing exercises, and we advise the patient to avoid allergen factors. Surgical management, the most preferred mode is of functional endoscopic sinus surgery, and alternatively, we can also go for polypectomy. Thank you. Hello, am I audible?
Yes, you're audible. You can stop presenting, and sir or ma'am, you can go ahead.
Hello.
Hello.
Yes,
Hello, Padmavati, can you hear me?
Yes, ma'am. Yes, ma'am. Good evening, ma'am.
Yeah, good evening, good evening. Then followed by surgery. What is the percentage of recurrence of polyps?
Ma'am, I'm not sure of the exact value, but it has a high chance of recurrence.
Okay. Then do you have any conservative line of management to prevent the recurrences? Or again, you have to go for surgery?
I'm not sure, ma'am. I think we have to go for, I believe functional endoscopic sinus surgery is useful to prevent recurrences. I'm not sure of alternative methods.
Okay, okay. Any steroidal spray will helpful?
Ma'am, dexamethasone or fluticasone?
Okay. In this patient, why you did the absolute eosinophil count?
Ma'am, because he has history of allergic rhinitis. So you check for his eosinophil count. Eosinophil count increases in cases of allergies.
Okay. Any family history of allergy was there in this patient, or only the patient is allergic to the allergens?
Ma'am, only patient. There's no family history.
Family history. Okay.
Padmavati.
Yes, sir. Good evening, sir.
Yes, good evening. Good evening. If you found there is eosinophilia, what the treatment?
Eosinophilia.
Yeah.
Sir, we can because he is a known case of allergic rhinitis. We can continue the steroid drugs he was already on for the same. Maybe increase the dose.
Yeah.
Also prescribe antihistaminics. And yes, sir. Maybe we can try.
Else? Anything else?
Parasites. Maybe he has a parasitic infection. So we could investigate for that also.
Okay.
So
what if he found on investigation, if he found the parasitic infection, what is the treatment? Any drug?
albendazole, sir.
Sorry, albendazole. In addition to that, any specific drug?
Ivermectin. I'm not sure. I just know ivermectin.
Okay, fine. That's all from my side.
Okay. Ma'am, you have any more questions?
Hello, Padmavati.
Yes, ma'am. Hello.
Yeah, can you name some antihistamines? Because you are presenting allergic rhinitis, no? So if you know any antihistamine, just name them. If you know first generation, second generation, if you know, just mention.
Ma'am, promethazine, cinnarizine.
Nowadays, some non-sedative antihistamines.
Non-sedative. Ma'am, I forgot.
It's okay. You can go and read, okay?
Okay, ma'am.
Okay.
Thank you, ma'am. Abhilash, can I leave?
Yes, you can leave. Thank you so much.
Thank you, sir and ma'am. Thank you, Abhilash.
Thank you.
Hello, Setu. Am I audible? Hello. Audible? Hello. Yes, Setu, I think you are visible.
Yes.
Yes. Okay. So you have to start with your introduction. You can start sharing the screen right now only, so as to save few seconds. Okay. And as soon as your introduction gets over, I'll start the timer. The time limit is 10 minutes, as you know. I'll interrupt you at 2 points, 5 minutes and 9 minutes. Okay. You may go ahead.
A very good afternoon. My name is Setu Dudley. I am an intern from Lokmanya Tilak Municipal Medical College and General Hospital in Mumbai. And today I will be presenting to you a case of Rett syndrome. May I start?
Yes, please start.
Okay, start.
This case was of a 3.5-year-old girl, first by birth order, born out of a non-consanguineous marriage, who was brought by her mother to the pediatric emergency department with chief complaints of neuroregression since the age of 8 months, some involuntary hand movements since the past 2 years, difficulty walking with frequent falls since the past 1.5 to 2 years, and seizures since 5 days. The child was apparently all right 2 years ago when her parents noticed that she had delay in development and began regressing. At the age of 2, her parents noticed that she had loss of purposeful use of hands and made some repetitive hand movements. A few months later, her parents noticed that she had an unbalanced gait and suffered from frequent falls while walking. 5 days before presentation at 2 in the afternoon, the child had a seizure while playing. The semiology was described as generalized stiffening of the whole body with a staring look, impaired awareness with upward rolling of eyeballs. The episode lasted for 30 seconds, followed by a postictal drowsiness of 4 to 5 minutes. It was not associated with fever, altered sensorium, and had no history of bowel or bladder incontinence. An hour later, the child had another episode of similar semiology, for which she was treated in a private hospital with clobazam. At 12:30 that night, she had another episode with similar semiology, after which she was brought to our institution. For initial management, she was given a loading dose of phenytoin. However, short-lasting seizures persisted, after which levetiracetam was added. She was then transferred to the ward for further evaluation. Developmental history. On gross motor development, she developed head holding at 4 to 5 months. She began to stand with support at 10 months. She began walking without support at 1 year, 8 months. However, she did not achieve the milestone of running and regressed to walking with support at the age of 2 years and then developed an unbalanced gait. Her developmental age was 1 year with a developmental quotient of 28.3%. In the fine motor domain, she developed her bilateral approach at 5 months and unilateral approach at 10 months. She did not develop her pincer grasp. She had poor fine motor coordination since the age of 15 to 18 months. She had a certain hand repetitive motion, which included putting her hand in her mouth, tapping her forehead and her hands, and she did not develop any new hand skills. Her developmental quotient is 14.3%. In the social domain, she began recognizing her mother at 4 months, however, did not develop stranger anxiety. She did not play with her toys or her peers, but she preferred to play with her clothes, which she rubbed between her hands and over her face and then put into her mouth. Her developmental age in the social domain was less than 6 months with a developmental quotient of 7.2%. In the language domain, she could only speak one word with meaning. She had developed normally till the age of 6 months. However, she did not develop the domain, she did not develop the milestone of 2 words with meaning. Her developmental quotient was 6.4%. In the cognitive domain, she had normal developmental 7 months of age, after which her parents noticed cognitive decline. She had normal vision and hearing and is now completely dependent on her parents for activities of daily living.
6 minutes over.
As you can see in this graph, there was decline in development in all domains. However, there was a greater decline in cognition, social, and language domains. Therefore, she had severe global developmental delay, which was differential. She had developmental regression with a global developmental quotient of 16.6%. Her family, natal, and socioeconomic history were uneventful. On examination, the child was awake, irritable, was not interested in her surrounding, and had poor eye contact. She had stable vitals, and non-purposeful hand movements, such as hand wringing movements and tapping her forehead and mouth, were seen. On anthropometry, her head circumference was 43 centimeters, which was less than -3 standard deviation for age, indicating microcephaly. On central nervous system examination, the child was awake, apathetic, irritable, and completely dependent on her parents. Her cranial nerve examination was normal. She had hypotonia in all 4 limbs with a power greater than 3/5, reflexes 2+. She had an ataxic gait. She had poor fine motor coordination. She had no signs of meningeal irritation. Sensory examination could not be done as the child was not cooperative. Her involuntary movements are shown in this video. Therefore, my impression is that of a 3.5-year-old female with normal development till 7 months of age, followed by global developmental delay and regression in cognitive and motor domains, with microcephaly, with poor eye contact, with loss of purposeful use of hands, with hand wringing movements, with ataxic gait. Our differentials included several disorders from the autism spectrum disorder. However, the specific hand wringing movements indicated a provisional diagnosis of Rett syndrome.
1 minute more.
Investigation. Her MRI, EEG were normal. No metabolic abnormalities were found. However, genetic testing revealed a mutation in the MECP2 gene, which was consistent with the diagnosis of Rett syndrome. Therefore, the diagnosis was classic Rett syndrome. Her treatment included symptomatic treatment, genetic counseling, sensory integration, and occupational therapy. Rett syndrome is a rare progressive neurodevelopmental disorder which is found almost exclusively in girls. It has a classic variation. Classic Rett syndrome has a mutation in the MECP2 gene. However, several variants are also found. This syndrome is severely undiagnosed, and therefore, when a young female presents with such symptoms, it is important that we suspect it, diagnose it, and improve the prognosis. Thank you.
Hello, Setu, can you hear me?
Ma'am.
Hello.
Yes, ma'am.
Yeah. What differential diagnosis you have given for Rett syndrome? Differential diagnosis.
Ma'am, we had a differential. Initially, her differential diagnosis included cerebral palsy, included a wide variation of autism spectrum disorder, and also Angelman syndrome. However, we noticed her specific hand wringing movement and the regression of her domains, which ruled out most of the autism spectrum disorder and definitely ruled out cerebral palsy. And therefore, the suspicion was towards Rett syndrome, which was confirmed with the genetic testing.
Okay. Can you call this disease a neurodegenerative or neurodevelopmental?
And it is neurodegenerative because as the age increases in these children, there is degeneration seen on MRI scans. not at this age, and also neurodevelopmental, because the classic finding is developmental delay, and more importantly, there more than delay, there is developmental regression in these children. They gain their milestones and then lose it, which is why I described it as degenerative and neurodevelopmental disorder.
Lifespan, actually, they're expecting lifespan.
Ma'am, most of these patients live well into adulthood. However, they have a lot of comorbidities, including certain GI disorders. They have heart disorders. They develop breathing disorders, and many of them develop Parkinsonism-like symptoms like tremors and rigidity and breathing difficulties. They have a long life, but they are dependent for most of it.
Okay, last question from my side. What is this one? Any treatments means is only the symptomatic treatment or any specific treatment is there?
Ma'am, just like most neurodevelopmental disorders, there is no specific treatment. However, the prognosis is extremely good when diagnosed early and occupational therapy is started before most of the milestones are lost. There is a current research going on world over and in a couple of hospitals in Mumbai also, which are trying the drug Sarizotam for the breathing difficulties that many of them face in their 20s. And there is the Rett Syndrome Association of India for mental and psychological support for these children and their family members.
Okay, what about the incidence?
Ma'am, because of early diagnosis, now the incidence is almost 1 in 20,000. Earlier, about 10-15 years ago, it was 1 in 100,000.
Can you elaborate this one? MECP2. What is the MECP2?
Ma'am, the MECP2 gene it's found on the X chromosome. There is pleiotropy on this gene, which leads to a variety of symptoms found. Since it's on the X syndrome, most of the male fetuses die in utero with this mutation. And apart from MECP2, there is the FOX gene and which has a mutation which can cause a variant of Rett syndrome. There is also the CDKL5 gene, which has another variant. However, these variants are more severe, with seizures usually in the first months of life. The classic hand-wringing movements are seen most commonly in the mutation of the MECP2 gene.
Hello.
Yes, sir.
Hello. Yeah. I'm really happy after, your history was quite elaborative and even your examination. One thing I would like to ask, that is, did you ask drug history of a mother actually during the childbearing age?
Yes, sir. The mother she has had no medical history that was significant. She has been completely vaccinated. She has had all her antenatal vaccinations, and apart from her standard multivitamin, iron and calcium supplement, she has had no other medication during her pregnancy.
No, particularly in this context.
So she has, even in this context, she has no history of any disorder, no illicit drug use, and none of the drugs that are commonly known to cause any of these disorders were used by the mother. Not
what
just
are the problems? Okay.
But during her entire lifetime, several anti-epileptics or even lithium is known to cause certain mutations that can lead to disorders like the Rett syndrome, and alcohol or any illicit drug, especially cocaine. But she denies use of any illicit drug use, and there was no medical history of any drug that was prescribed to her.
What about tobacco?
She was a non-smoker and does not chew tobacco at all.
Okay. So what are the problems of management of this disease?
I'm sorry?
What are the problems we commonly face in managing this disease?
So this disease...
What are the difficulties we face?
The difficulties are, so if I mention in this particular patient, she needed occupational and physical therapy on a weekly basis, which was difficult because they come from a lower economic background to travel on a weekly basis to bring their child. And most of these children take a long time to show any improvement, which has a psychological effect on the parents, and they are not compliant because of that, because they feel that no treatment is working. And along with that, because many of these cases are lost to follow up, a lot of the uh, a lot of the diseases or the complications that are found later in life are not diagnosed early. Several breathing difficulties or several heart problems, even atherosclerosis is more common in these cases. However, they are not diagnosed early because these children are lost to follow up or are neglected by the family, and therefore the morbidity and mortality increases later in their age.
Any possibility of the genetic predisposition?
Sir, only about 1% is hereditary. Most of it is sporadic.
Okay. Okay, thanks. That's all from my side.
Thank you so much, Setu. You can leave the call. Jeffy, you can turn your camera and mic on.
Yes.
Okay, hi. So start your screen sharing. Yes. And as soon as you introduce yourself, your timer will start. I'll interrupt you at 2 points, 5 minutes and 9 minutes. Okay, you may start with the introduction.
Good afternoon. I'm Jeffy. I'm a third-year medical student from PSG, and today I'm presenting a case of a rare cause of swelling in the arm of a child, a basilic pseudoaneurysm. True aneurysms involve all the layers of the vessel wall, while false aneurysms have a wall defect through which the hematoma communicates with the intravascular channel. Pseudoaneurysms involving the veins are rare in the pediatric age group. It can be primary or it can be secondary to trauma or iatrogenic injury. It can present with pain or it can be asymptomatic. It can even rupture and cause a thromboembolism. Coming to the case, a 12-year-old girl child came with chief complaints of painful swelling on her left arm. The pain and swelling was present for a month. There was no history of trauma or any systemic disease. Her personal history, past history, medical history, and drug history had no significance, and there were no history of collagen disorders in her family. To summarize the history, 12-year-old girl, pain, swelling, left arm, 1 month. Coming to the examination, on general examination, she was afebrile, conscious, oriented to time, place, and person. There was no pallor, icterus, lymphadenopathy, clubbing, cyanosis, or any pitting edema. On local examination, a compressible swelling of 3 by 3 centimeters was present on the medial aspect of the left arm. It was about 3 centimeters above the elbow. It was tender and it was non-pulsatile. The swelling reduced in elevation of the upper limb. On systemic examination, her cardiovascular system, respiratory system, central nervous system, and per abdomen were all normal with no abnormalities detected. Coming to the differential diagnosis, a venous malformation was entertained, but in the ultrasound, it could demonstrate heterogeneous vascular spaces, which are the hallmarks of venous malformations. In contrast, our patient's ultrasound revealed a well-defined heteroechoic area with no internal vascularity. A CT angiogram was done to confirm this, and finally, a diagnosis of basilic pseudoaneurysm was made. The excised specimen on histopathological examination showed medial hypertrophy in the inner lumen. An organizing thrombus was present and with a neoepithelioid vessels, and also the adventitia had mixed cellular infiltrates. Our patient continued to have pain, so we planned for an excision, and it was treated with a surgical excision. She's now 13 years old and she's on follow-up. She's asymptomatic with no recurrence so far. Pseudoaneurysms after arterial puncture have been reported, but the ones involving the veins are rare. All cases have been attributed to trauma or iatrogenic injury in the form of venipuncture in the elbow, or as a complication of creation of arteriovenous fistula for hemodialysis. The most accepted theory here is the congenital underdevelopment of the connective tissue, causing focal weakness of the vessel wall. But in our patient, there was no history of trauma, and the side, which is the medial aspect of the arm, was unlikely for injury. She was normal with no family history or clinical evidence of collagen disorders. A similar case has not been reported in the pediatric age group, but one case of a 58-year-old man of a primary vesselic pseudoaneurysm has been there in literature. He was advised regular follow-up without surgical management since he did not have any life-threatening complications. So the take-home messages would be to suspect a pseudoaneurysm when there is a compressible swelling on the elevation of the limb, Doppler, MRI, CT are diagnostic. Complications include thrombosis, embolism, rupture, pain and compression, and surgical resection is curative. These are my references. Thank you.
Thank you so much, Jeffy. Judges, you can ask the questions.
Hello.
Yes, ma'am.
Yeah. On what basis you thought of it is aneurysms? What are the clinical signs of aneurysm?
Yes, ma'am. So firstly, on elevation of the limb, there was a decrease in size. So we thought it's an aneurysm, and also it was a compressible swelling. So after compression, it did increase in size.
Okay. Any auscultation you did?
Yes, ma'am. There was no brood.
Brie was not there. What is the incidence of this basilic aneurysm you told?
Ma'am,
Is it a rare?
Venous aneurysms have an incidence of 0.1, but basilic aneurysm, there is no cases. Only one is there in the pediatric age group so far in literature.
Okay. Any recurrence of aneurysm is there followed by the surgery?
Yes, ma'am. There is a recurrence of 10% in venous aneurysms.
Okay. What about the arterial?
Arterial also there's a recurrence, ma'am. The most common is the aortic aneurysm.
Hello, Jeff.
Yes, sir.
Hello.
Yes, sir.
Do you know any drug which AMS addiction, especially it's can cause especially a thickening of medial layer of media of the vessel? Any drug?
No, sir. I'm not sure.
I will narrow your answer. Okay, spectrum of your answer. That is any addictive drug commonly used as a addiction.
Cocaine, sir.
No. Okay. So, what do you treatment you thought? One more question. That is during when you started investigating the patient, you said normal sonography you did. That is, it was
Yes,
normal sonography or duplex scan?
it was a duplex scan, sir.
Doppler.
Yes, sir. Doppler also, sir.
Okay. So, is it possible to think of operating on this patient, if at all it is required, without doing any invasive angiography or something, but just based on the Doppler study? Is it possible? Can you go ahead with the just Doppler study?
Yes, sir. Yes, sir. There are cases where they have done that.
Okay. Fine. Good.
Thank you, ma'am.
Hello.
Yes. Jeffy?
Yes, ma'am.
Hello. What differential diagnosis you told, Jeffy?
Venous malformation, ma'am.
Only one. This one.
Yes, ma'am.
Any others? Just as a compressible swelling. Any other things you thought of differential diagnosis?
Seroma.
Okay. Any others? All surgical swellings? Any others apart from that?
Surgical
Jeffy,
swelling.
why you thought of seroma?
Sir, because of the compressibility.
Just compressible. What is the difference between compressibility and reducibility?
Reducible means it will stay, and compressible means after the pressure it rises.
So it will stay, but there is difference between there's again the recurrence, no?
Yes, sir.
How it will recur? I mean, reappear back.
Yes, sir.
In case of
Reappears back.
reduction. In case of reduction, reducible swelling and compressive. In compressibility, it will automatically reappear, no?
Yes, sir.
Whereas in reducible swelling,
It will stay.
what you have to do?
I'm
There is
not
contour pressure is needed.
okay, sir.
Okay, fine.
Ma'am, your questions?
Finished.
Okay. Thank you so much, Jeffrey. And you can leave the call. Archika, you may start sharing your screen.
Okay.
After you introduce yourself, your 10 minutes timer will start, and I'll interrupt you at 2 points, 5 minutes, and 9 minutes. Okay?
Okay.
Go ahead.
Hello, can you see my screen? Hello?
Yeah, no.
Just a second. No, it's not visible yet.
Yes, she is not visible. She is not visible.
Archika, your PPT is not visible. You haven't started screen sharing yet.
I don't know what's happening. Like I'm sharing it, but it's not coming on the screen.
Just a second.
Okay. Like now, please.
Screen sharing has started.
Okay. So my name is Anshika Sharma. I am second year medical student studying in Kharkiv National Medical University. So here I am presenting my case study on the hypothyroidism. So a female patient was admitted in the General Medicine on 11/3/2020. Patient demographic details: name Manisha, age 45 years, sex female, department General Medicine, date of admission 11/3/2020, and date of departure 15/3/2020. Like it's based on true story, like on my mother. Chief complaints like swelling on neck, history of personal illness, swelling in front of neck for 2 months, which was noticed by her husband, increased tiredness, headache, pain in cheek. Negative history, mental health problem, dull aching pain, sudden onset of swelling with no aggravating or relieving factors. Personal history, non-smoker, non-alcoholic, no allergy, and married. Past history, stomach, hypotension. Drug history, no history, any significant medication. Medical history, anemia, menopause at the age of 37. Family history, no history of any thyroid disease in the family. So the summary is like a 45-year-old lady presented with complaints of swelling in front of the neck for 2 months, is associated with dull aching pain over the swelling for a month, with headache and weight gain, apart from which other symptoms are also observed. General examination. Swelling around legs, slower reflexes, dry skin. The lady was conscious, oriented to time and person, and snoring at the night. Local examination, swelling in the aspect of the neck in the region of thyroid. A low border is seen. Swelling moves with deglutition. Oval in shape, surface appear to be smooth. Margin well defined. Skin over the swelling normal. No scar, no sinus, as you can see in this picture. Systemic examination. Central nervous system, no focal neurological deficit. CVS S1, S2, head, no murmur, spine and cranium normal, temperature, BP and pulse, as you can see in this table. Differential diagnosis: Addison disease, goiter, iodine deficiency, thyroid lymphoma, no toxic goiter, autoimmune thyroid disease. A blood test: hypothyroidism can be detected by different blood tests. A TSS test, a thyroid stimulating hormone, or the TSS, is a blood test that measures the amount of thyroxine that the thyroid is being signaled to make. If you have abnormally low level of TSH, it could make you have hypothyroidism, lab investigations. So the final diagnosis is hypothyroidism, and the treatment is like standard treatment for hypothyroidism involves the daily use of the synthetic thyroid hormone, levothyroxine. This is a synthetic steroid which is like given nasally, and this oral medication restores adequate hormone level, reversing the signals and symptoms of hypothyroidism. You will likely start to feel better soon after you start treatment. Other drugs and can also be given. Advice: eating a healthy, well-balanced diet rich in fruits and vegetables, whole grains, and lean protein can help you manage your weight. Limit processed food and those high in fat and sugar. Proper treatment and also help you manage your weight and other symptoms of hypothyroidism. Thank you for your attention.
Thank you so much, Anshika. Judges, you can go ahead.
Hello.
Hello. Hello.
Hello.
Hello, Anshika. What about her menstrual history and obstetric history? Can you hear me?
Yeah, I can hear you. Can you please repeat?
What about her menstrual history at present? And second one is her obstetric history.
Right now, like she's not having like a menstrual cycle. She was having anemia in very last period, till long time. But she was getting treatment, but not like daily doses. So suddenly all these problem happened, and she got admitted in the DMC Ludhiana over this.
No. Has she got regular menstrual periods at present, or it is a menopause?
Menopause. Like
She
at the
reached
age of, yeah.
She reached menopause already. Hello.
Yeah, at the age of at the age of 37.
She reached menopause. Oh.
Yes.
Let's go.
Hello. Hello.
Yes, ma'am. Go ahead.
Hello.
Yeah. What do you mean by subclinical hypothyroidism? Have you heard this entity? Subclinical hypothyroidism.
Yeah, I have listened. Subclinical, after some symptoms you can see like secondary. Like I don't know it properly because till now I didn't studied over this. But
Okay.
yeah.
At present, what about her TSH level in the given patient? No, what is the TSH level?
Right now, like she's taking medication, so like it's normal. She's not having that much swelling, and like the goiter that she was like earlier, it was made like now it's like very little left. Like she's not getting recovery from that.
Thyroid, it is a systemic disease, or it is this one? Thyroid. Can you hear
Yeah.
me?
Yes, I can hear you.
Yeah. Any cardiac symptoms? Can you mention what is the cardiac effects of hypothyroidism?
Like abnormal BP, pulse rate, and thyroid is not a it can be congenital, or it can be like acquired. Like congenital, in case of it present during the birth, and that case is known as cretinism. And if it is acquired, it is called, in adults it's called hypothyroidism.
No, not like that. What are the cardiac effects? If the patient has got hypothyroidism, what are the cardiac effects?
Abnormal BP and a pulse rate, and temperature can be like uneven, like normal to little bit higher.
Okay, sir will ask.
Okay, ma'am.
Hello.
Thank you. Hello, sir.
Yeah,
Good afternoon.
I forgot her name. I forgot her name. Good afternoon. Good
Sir,
evening.
my name is
I
Anshika
forgot your
Sharma.
name.
Anshika Sharma.
Ansika, if at all patient is coming with some toxic symptoms, or in case of toxic symptoms, as a combination of overall effect of thyroid hormone, nowadays we term rather than naming it is hyperthyroidism, we call it is thyrotoxicosis. Why it is so?
So because of increasing toxicity, sir, mainly like toxicity, sir, sir, in case of hyperthyroidism or in case of hypothyroidism, you are asking.
No, just answer me. Oh,
Okay. So, sir, toxicity, because sir, like it's destroying various because as thyroid gland maintains the produces certain hormones.
Sorry. No. You are deviating.
I'm not getting
You are
any
not.
idea.
Yeah. Okay, so as I want to ask further what the question asked by madam. So in case of hypothyroidism, there are cardiovascular impact on that hypothyroidism. Okay, if patient is having hyper, okay, toxic quite. So what are the possibility of, what are the various toxic effects seen on the cardiovascular system? And why do you get tachycardia in case of thyrotoxicosis?
Sir,
What is
in
the
case
reason
of
of tachycardia?
sir, increase the increase
What is
BP
the reason of tachycardia? One sentence you should ask. You mean it is because of the increase of metabolism? Hello? Hello?
Anshika, you're there?
Anshika? Hello?
I guess she's having some network issues.
Screen is
Okay.
frozen. Her screen is frozen.
Yes. We'll wait for 30 or 40 seconds and then we'll move on to the next participant. Okay, wait if she rejoins.
Hello, sir.
Okay, she is here.
In short, answer lies there where the if you know the effect of thyroxine hormone on myocardium. How does it act on myocardium?
Sir, thyroxine act on myocardium. Sir,
How? What is the end result? That is what pharmacokinetic and pharmacodynamic of thyroxine. Does it
yes.
changes the or does it change the any heart or force of contraction of myocardium? Thyroxine hormone.
Yeah,
Does it
yes, sir.
has
Yes,
any effect?
yes, sir. It changes.
What is that? What is that?
Yes, sir. It has an effect.
What is that
So,
effect? Okay, ठीक है.
Hello, Anshika.
Hello.
Yeah, it is not this one criticizing. It is just to encourage you. Okay, you are in second year now. Hello, Anshika.
Yeah, actually, yes,
That
I
is
can
the
hear you.
reason.
Actually,
That is the reason why I asked her that question. Because she is in second year, she should know.
Yes.
okay,
Anshika.
sir. Yes, sir. Yes, ma'am.
No. Just I want to say, because before you answer, no, always you should listen to the questions, what they are asked. Okay, not what you know. What the questions are asked, only thing relevant answer should be there. Okay, it is only the suggestion, not a criticism. Okay. Okay.
No. Okay.
Chalo, best of luck. Chalo,
Thank you.
bye.
Thank you.
Okay.
Thank you so much, Anshika. Anna, you can go ahead with your setup. Yes, so you'll start by introducing yourself. You can start sharing your screen. As soon as your introduction is over, your 10 minutes timer will start. I'll interrupt you at 2 points, 5 minutes and 9 minutes. Okay, you may go ahead.
Hi, good morning. Can you see my screen?
Yes, your screen is visible.
Yeah, okay. One sec.
What's her name, Abhilash?
One sec.
Her name is Anna, sir.
Anna.
Good morning.
Okay.
My name is Anna Maria George. I'm a pre-final medical student from Odessa National Medical University from Ukraine. Today, my case presentation will be on the topic liver cirrhosis. So the patient's name is Mr. Clinton Gomez. He's a 75-year-old male. He's a Christian. Address is in Kottayam. He is a retired senior manager. Socioeconomic status is upper middle class. Date of admission and examination is 3rd July 2021. So when he came in, his chief complaints were that he had abdominal distension since 6 months, bilateral pedal edema since 3 months, moderate shortness of breathing since 5 days. So history of presenting illness. Mr. Clinton has been an alcoholic for approximately 40 years. He has been sober for 6 years now. He was diagnosed with liver cirrhosis 6 years ago. He was advised to take oral medicines and stop the use of alcohol. Now, 6 months ago, symptoms reappeared. There's abdominal distension, edema in the lower part of legs, and mild to moderate shortness of breathing. The disease had relapsed and therefore was admitted to the hospital for further investigation. Negative history, he has no history of fever or pain in abdomen, no confusion or altered sensorium, no history of vomiting of blood, no history of passage of dark colored stools. Personal history, his diet is mixed, appetite is decreased, sleep is disturbed. He has regular and normal bowel and bladder movements, smoking and alcohol consumption for 40 years, sober since 6 years, regular light exercise. Next is past medical history. He was diagnosed with alcoholic liver disease 6 years ago. No known cause of diabetes mellitus, hypertension, asthma, TB, or epilepsy. He has no history of allergies and drug allergies. He has hypothyroidism and benign prostatic hyperplasia. Past surgical history, he has a shoulder fracture and it's reconstructive surgery and appendectomy. Drug history, right now he is taking thyroxine 75 tablet, Silodal 4 mg capsule. Family history, no significant history, no history of similar complaints in family members. Summary, he's a 75-year-old male, presents with abdominal distension since 6 months, bilateral pedal edema since 3 months, and mild to moderate shortness of breathing since 12 days. Liver cirrhosis was diagnosed 6 years ago as a result of long periods of alcohol consumption, was sober since last 6 years. General examination, patient is conscious, cooperative, and well-oriented to time, space, and person. Patient is moderately built and nourished. No signs of pallor, icterus, cyanosis, clubbing, and lymphadenopathy. There's bipedal pitting edema. Then vitals and measurements. Height is 176 centimeter, weight 70 kg, temperature is 36.8 degrees Celsius. Pulse is 90 beats per minute. Respiration rate is 20 breaths per minute. Blood pressure is 110 upon 70 millimeters of mercury, and oxygen saturation is 98%. On local examination of the abdomen, inspection, size and shape, distended and flanks full, slightly visible veins. On superficial palpation, there is tenderness in the right hypochondrium. Abdominal girth is increased, approximately 34 inches. On deep palpation, there is moderately enlarged liver and spleen. Percussion, there is shifting dullness present and fluid thrill is also present. On auscultation, there is bowel sound present. The first picture shows percussion with shifting dullness, and the second picture shows steps for the superficial palpation of abdomen. Systemic examination. Cardiovascular system, S1 and S2 are heard, no murmurs. Respiratory system, normal vesicular breath sounds heard, no added sounds, slight cough but not productive, dyspnea in lying position. CNS, no focal deficits noted. Per rectal exam is normal, urinary system is normal. Differential diagnosis, alcoholic liver disease, viral hepatitis, Hep B and C, hemochromatosis, hepatocellular carcinoma. Investigations, liver function test, there's increased alkaline phosphate. ASC is to ALT ratio is greater than 2:1, which is characteristic for this disease. Decrease of total protein, decrease of albumin, increase of serum bilirubin and globulin. Prothrombin time is prolonged, creatinine. Ascites fluid test, abdominal US, CT scan, endoscopy, and liver biopsy. Significant test results. AST level is 187, ALT is 88. Albumin is 3.3, which is reduced slightly. Bilirubin is increased 2.2. Prothrombin time is also increased 23.3. INR is also increased 1.8. Creatinine is increased 2.2, hemoglobin 11.8, WBC
5 minutes done.
600, platelets 61,000. Abdominal ultrasound, there was coarse echogenic parenchyma, dilated portal vein, and splenomegaly. The liver ultrasound in the picture shows increased echogenicity and surface nodularity. So my final diagnosis is cirrhosis of liver with features of portal hypertension with initial stage of hepatorenal syndrome. Treatment, monitor for complications, esophageal varices, hepatic encephalopathy, and hepatorenal syndrome. Maximize liver function. Diet should be adequate calories and protein, 75 to 100 grams per day. Restrict fluid less than 1000 ml per day. Restrict sodium intake, 2 egg whites per day. Inject opinurine 1 ampule to be added in 5% dextrose. Adequate rest to maximize regeneration of liver cells. Medication, aldactone 25 mg tab, Dieter 5 mg tab, Hepapro, Pantocid 40 mg tab, Usolive 300 mg tab. Injection vitamin K 1 ampule in IV. Advice, adherence to treatment regimen, regular follow-up, immediate checkup in case of symptoms like confusion, altered sleep patterns, vomiting of blood, blood and stool, regular creatinine check. Thank you so much.
Thank you so much, Anna.
Hello, Anna, can you
So
hear me?
you can go ahead.
Yes, ma'am. Good afternoon.
Yeah, good afternoon. What are the signs of portal hypertension?
Ma'am, signs of portal hypertension can be ascites. Then it can be
Because in the diagnosis you have mentioned, no, signs of portal, cirrhosis of liver with portal hypertension. So what are the signs of portal hypertension?
main signs is ascites and then bilateral pedal edema. Then these are the main symptoms.
No. Those things will occur even in only cirrhosis without portal hypertension. Has she had any splenomegaly?
Yes, ma'am, he has.
Then he has got engorged veins.
Ma'am, only mild visible vein.
No, same. Engorged veins over the abdomen.
Yes, caput medusae is present.
Have you auscultated?
Yes, ma'am. Only normal bowel sounds were heard.
Over the, you told no caput medusae. Have you auscultated over that area?
Yes, ma'am. There was shifting dullness.
Caput medusae you told, no?
Yes, ma'am.
Where you have to look for caput medusae?
Ma'am, in the distended abdomen.
It is one of the sign. Caput medusae. You only told. What you told, no? Same thing I'm asking.
Yes, ma'am. Ma'am, I'm not sure of the answer.
Okay, have you examined the patient?
No, not exactly.
Or because of COVID, you are not this one, examine the patient?
Ma'am, actually, no, I haven't examined the patient myself.
No, you have to examine it because you're presenting means with all precautions, you have to examine the patient. Yes or no? Because clinical signs, in all the patients, you will not get the book picture. In a different individuals, different signs will be there, or some of the signs may not be there. Yes or no? In this patient, endoscopy was done, upper GI endoscopy.
No, ma'am, because there was no vomiting of blood or blood in stool, so it was not done.
No. He's a alcoholic since years together. Yes or no?
Yes.
So one of the complications of cirrhosis of liver is esophageal varices. Yes or no? Suddenly they'll come with a painless hematemesis. They'll not be having any pain. You can prevent one of the major complications provided if you do the endoscopy early, and you can give you some medications for that.
Yes,
okay. And last questions you told hepatorenal syndrome type 1 something you told, no? What do you mean by that?
Ma'am, mild hepatorenal syndrome because his creatinine level is increased. It is 2.2.
Do you know what are the types of hepatorenal syndrome?
No, ma'am, I'm not sure of the answer.
No, because it is not called mild, moderate, severe. It is type 1 and type 2. Okay.
Yes, ma'am.
Okay, sir will ask question.
Anna.
Yes, sir. Good afternoon.
Do you know? Good afternoon. Do you know what is normal portal pressure?
Sir, portal pressure 5 to 12 mmHg.
12. Which book you referring?
So portal venous pressure greater than 12 mg is
How do you
considered as
calculate that?
so flow intraresistant.
So you have investigated the patient, some blood investigation and done. So what do you think? How much his liver function reserve is there? If at all he, I mean, if you want to undergo this some surgical procedure or some other hypersplenism or other, would you like to categorize him in that child's criteria to have an idea about the hepatic liver reserve, functional liver
So which criteria?
capacity, child's
No.
criteria?
No, sir.
Are you
I'm not
aware
sure.
of that?
No, I don't know about it.
Okay, so okay. Do you know the treatment of hepatic coma?
You mean, sir, hepatic encephalopathy?
Right.
Sir, it is a reversible thing. Sir, I am not sure of it.
Okay. Okay, fine.
Hello.
Yes, ma'am.
Hello, Anna. Any effects of chronic cirrhosis of liver? Any effects over the lungs?
Ma'am, he is having dyspnea in lying
How will you call there is no hepatorenal syndrome you told, no?
Hepatopulmonary syndrome.
What do you mean by that? If you know, you answer.
No, ma'am, I do not know about it.
Okay. What advice you want to give the patient?
Ma'am, adhere to the medicines given and stay sober and away from alcohol. Then in case he finds vomiting or blood in stool, he should immediately get hospitalized and checked up. So if in case there is esophageal varices and bleeding, he should get it band ligated. Then if he has in case some altered sleep patterns, like he's awake at night and morning he's drowsy, or he has some confusion or some sort, he has to get checked up as well for in case of hepatic encephalopathy.
What is the gold standard investigation in cirrhosis of liver?
That
will clinch your diagnosis.
Liver biopsy.
Liver biopsy. What do you mean by Lennox cirrhosis?
Ma'am, it is the alcoholic liver cirrhosis is called Lennox with Lennox cirrhosis.
It is a micronodular or macronodular or mixed?
Micronodular.
It is micronodular. Okay. Can you tell some of the surgical mode of treatment?
Ma'am, surgical treatment over here only possible is liver transplant.
Before that, if the patient got refractory ascites.
Refractory ascites. I am not sure, ma'am, what we can be done.
Okay. Have you heard tips?
No,
TIPS. Have you heard?
No.
It's okay. When just go and read. When you present the case, you should know the things. Okay, just go and read.
Anna, just one last question. Any idea? I mean, what could be the logic of behind this to reduce it? Because as you know, there is shunting of blood. Okay, so what could be the logic to give some invasive procedure or surgery? What sort of surgeries we are going to think of? Hello,
sir.
So that it will even hepatic pressure will get reduced, and this chance of hepatorenal syndrome will come down. Hello.
Yes, sir.
Anna, do you know something about hypersplenism? Hello.
Sir, I'm not sure about what you're talking about.
Okay, fine.
Thank you so much, Anna. I guess both the judges are done with their questions. You can leave the call.
Yeah.
Hello. Sorry. Riturima, you're there?
From my side, sir.
Good afternoon. Yes, she's here. So Riturima, you'll.
Yes, sir.
As soon as your introduction gets over, you'll start with your introduction. As soon as your introduction gets over, your 10 minutes timer will start. Okay. And I'll interrupt you at 2 points, 5 minutes and 9 minutes, so that you know the timings. And you may start sharing your screen now so as to save few seconds after your introduction.
Okay, sir.
You may start your introduction just after sharing your screen.
There is problem with audio here.
Hello, sir. Am I audible?
Yes.
Ma'am, am I audible?
You can proceed.
Okay. Thank you. A very good afternoon to one and all. First of all, I want to thank IAMS for giving me the opportunity to present a case on adult ileocholic interception, a case report. I am Riturima Vaidya, second year MBBS student from Dr. Babasaheb Ambedkar Medical College. Before starting, I just want to give the disclaimer that it's a purely genuine case taken under the guidance of Dr. Shardul Vikram Gupta, and we have put in all the efforts to maintain the anonymity of the patient. The patient is Mr. X, who is 32 years old male, and he is a resident of Northwest Delhi. He is married and he is literate, and he belongs to moderate socio-economic background. He presented with the chief complaints of recurrent pain at his central abdomen for 6 months. The patient was apparently well 6 months back, but when after that, gradually he started having pain in the central abdomen, and he had 6 recurrent episodes of pain associated with nausea and vomiting, and there was no radiation or the shifting of the pain. The patient also had no history of upper GI bleed or melena, no history of weight loss or loss of appetite, and no family history of tuberculosis. The patient has a history of chronic constipation. Patient is under syrup lactulose on regular basis due to constipation. He is a non-smoker, non-alcoholic, and no history of allergy to any drugs or anything. He has no previous history of trauma or accident, no previous history of surgery, diabetes mellitus type 2, tuberculosis, hypertension, or neither any history of hypothyroidism. As said before, in the medical history, he has no history of diabetes mellitus, hypertension, hypothyroidism, and tuberculosis. The previous drug history includes only syrup lactulose intake on regular basis for constipation, and no other history of drug intake. The family had no significant history related to tuberculosis or cancer or any sort of GI obstruction. So far, we came to know that we have a 32-year male who has presented with pain in the central abdomen of insidious onset. He had 6 recurrent episodes of pain associated with nausea and vomiting in last 6 months. The patient had no history of hypertension, hypothyroidism, or diabetes mellitus type 2. The patient was under chronic lactulose intake. Now let's proceed with the examinations. Under the general physical examination, the weight and height were measured and the BMI came out to be normal. There was no reported lymphadenopathy, no pallor, no jaundice, and negative Shamrock sign. The vitals were normal and the patient was afebrile. On local examination of the abdomen, it was found to be soft and tender. A lump was palpable in the right upper quadrant, which was moving in both the axes. On inspection, there was fullness in the right upper quadrant of the abdomen with no definitive lumps in. Rest of the quadrants were moving evenly with respiration. Umbilicus was central and no scar mark or dilated veins were present. On palpation, we came to know that there is a vague lump of 5 into 6 centimeter, which is moving with respiration. It was mobile in both the horizontal and vertical directions. On auscultations, normal bowel sounds were present. On percussion, the mass was dull to percussion, and the mass is separated from the liver as apparent. Apparently, we can see that there is a discontinuity with the hepatic dullness, and there was no free fluid in the abdomen. On digital rectal examination, no growth, neither any abnormality in the rectal mucosa was seen. Also, there was no prostactomegaly. Then we proceeded with the systemic examination. The respiratory system had bilateral air entry present with no added sound, which was normal. The cardiovascular system showed S1 and S2 sounds, which was absolutely normal. And the CNS examination had no neurological deficit as the patient was well oriented with time, place. Then we proceeded with the diagnosis. The doctor prescribed him diagnostic laparoscopy and histopathological findings, that is biopsy. In the diagnostic laparoscopy, we can see that the ileum is intercepting into the colon. Laparoscopic image, here we have another image, the mass in the hepatic flexure lesion with empty transfer colon. And we have the histopathological findings that are suggestive of non-Hodgkin's lymphoma, which is clearly the lead point of the diagnosis, which we will gradually head over to. The doctor prescribed him investigations of CT and colonoscopy. The colonoscopy, we can see the typical sign, target sign that shows the ileocolic intussusception, and the CCT abdomen in the coronal section shows ileocolic intussusception, this region. Next up, we have the laparotomy image showing ileum is intersuscepting in the colon, and the specimen shows the cut section of the colon, cut section of the colon into the cecum, and artery of forceps is pointing towards the lead point. The lead point in our case is non-Hodgkin's lymphoma. The final diagnosis that we came to was an ileocolic TB, carcinoma of the right colon, that is the hepatic flexure, and final diagnosis was ileocolic intussusception based on CT abdomen, along with the lead point non-Hodgkin's lymphoma based on biopsy. We went ahead with lap-assisted right hemicolectomy. After surgical management, we had sent the patient for chemotherapy. Prognosis and advice. The patient has a good prognosis because the resection margins were negative and no tissue was left behind. And the patient is undergoing chemotherapy regularly after 3 weeks. And the patient is advised to follow up in Delhi State Cancer Institute for chemotherapy, regular follow-up in onco department and as surgery OPD. Our further plan is to repeat the CCT abdomen and colonoscopy at 1 year of chemotherapy. So,
1 more minute.
I would like to conclude that adult ileocolic intussusception is a rare and is usually associated with something malignant, unlike the that found in the children, which is generally idiopathic. Surgical explorations is the mainstay for the treatment in these cases. Most of the cases, the symptoms overlap with other disorders, so we may get confused. So the major take-home message is that we should consider this diagnosis in mind whenever we have a patient with constipation or any other symptoms related to the obstruction of the GI tract. Intussusception, let us just briefly define what is intussusception. It is the invagination of the distal part of the small intestine into the large intestine. In cases of children in the pediatric population, it may be managed by non-operative interventions, but in adult cases, as seen in this case, we need operative intervention. Thank you.
Thank you so much, Ridhima. Judges, you may proceed.
Hello. Hello, can you hear me?
Good afternoon.
Yeah.
Good afternoon.
Good afternoon. What is the clinical differential diagnosis you have made clinically? Clinically, what differential diagnosis you have made after seeing the lump in the abdomen or mass per abdomen?
Ma'am, since it was separated from the hepatic dullness, so we concluded that there will be some disorder in the GI tract itself. So we proceeded with the CT scan and colonoscopy.
No, correct.
We were
What
sure
differential? Means clearly, what differential diagnosis you have made, I am asking. Because in your differential diagnosis, you have written some investigations you have written. Differential diagnosis, under that heading, no, you have not written this one, diseases.
Yes, ma'am.
You written.
Yes, ma'am. Based on, ma'am, just a minute.
Yeah, differential diagnosis, just take out that PPT.
Yes, ma'am. Ma'am?
Yeah. Differential
here we have.
This is the final diagnosis. Differential diagnosis. Yeah.
Yes, ma'am.
So in the differential diagnosis, no, you have to write the diseases. Ileocecal tuberculosis or obstruction or intersusception, like that you have to write. Here written diagnostic laparoscopy. This is not the differential diagnosis. Histopathological findings. This is not the differential diagnosis. Differential diagnosis means based on the clinical signs and symptoms. At the bedside, what you come to the conclusion.
Yes, ma'am. Ma'am,
Okay.
actually, I guess I have included in this slide, this before the final diagnosis, I have just mentioned this ileocolic TB and carcinoma of the right colon.
These things will come. Correct. These things will come in the differential diagnosis.
Yes, ma'am.
Yes. What is the difference between the intersusception and obstruction, intestinal obstruction?
Obstruction can be due to many reasons, due to formation of tumors, due to any inborn error. But intersusception is the invagination. The one part of the GI tract completely enters the other part, and it's mostly related to the distal part of the small intestine, intersuscepting in the large intestine. So that's the difference.
Okay. Then this one, what is the important clinical sign of obstruction, intestinal obstruction? Clinical sign of intestinal obstruction.
Yes, ma'am. It will be vomiting after taking the meals.
No, yeah, I'm asking for the signs, not symptoms.
Okay. Ma'am, it will be a lump in the abdomen after.
Apart from that?
Ma'am, pain abdomen, acute pain in abdomen.
No, that is all symptoms. I'm asking the clinical signs. You are using your stethoscope and looking for something.
Yes, ma'am. Ma'am, for the obstructions, we will feel on palpation. We will feel lump.
Peristaltic sounds. What will happen in the intestinal obstruction?
It will be it won't be normal, obviously, and it will be less. The peristaltic movement will be less.
It will be less or more. What is Borg-me? Borg-me. You must have heard this name in your physiology.
Yes. It's like bubbling, like a sensation where we have the bubbling of the contents in the GI tract.
That's called increased frequency of peristaltic sounds. They're called Borg-me. Okay. Yeah. Where the peristaltic sounds will be absent, name one condition.
Ma'am, peristaltic in constipation.
Where it will be absent, yeah.
Despite obstruction, where you will find there is absence of peristaltic movement. Despite there is obstruction, there is functional obstruction.
Yes, ma'am.
Where you will find silent abdomen. Whereas you will find multiple air fluid level spreading throughout the extremity. Do you know the normal characteristic of peristaltic movement and frequency? How does the sound heard?
Sir, there is.
What is the frequency? How does it describe in belly and love?
So
normal vowel sound.
So normal vowel sound.
Characteristic. It is heard like. It is specifically mentioned the typical feature of normal vowel sound. And what is the frequency?
Sir, it is like 4 to 5 centimeter per minute. It's the rate at which peristalsis occurs.
4 to 5. Okay. Okay. Okay.
Apart from resection, any other mode of treatment in reception?
Ma'am, in case of adults, we will have to go with resection.
Okay. Any other modes?
And in pediatric age group? Pediatric age group, what madam asked, any alternative way of, minimally conservative way of management or conservative management, the typical interception?
With medications.
Sorry?
In pediatric age group, we can proceed with the cause of the interception.
The conservative way of management, where you are not thinking of doing any surgery. Invasive surgery, yes, radical surgery.
So, with
reduction therapy, reduction therapy. Have you read reducing this one?
Hydrostatic. Have you heard hydrostatic reduction?
Sir, I have heard about reduction therapy. I'm not aware about hydrostatic.
Okay. So, what are the salient feature, or what are the main objective of management any intestinal obstruction?
So, for any obstruction, first of all, we would like to know the cause of the obstruction, and then proceed with the. First of all, we will try to minimize the cause, and then if we will try not to intervene with surgery, but and we will try to try to make the bowel movement.
If at all you are thinking about the electrolyte imbalance in the case of obstructed or a constipated patient, what is which electrolyte specifically among that chloride, sodium, potassium, which one is more important as far as this obstruction is concerned?
Sir, I am not aware.
Which is aggravating, hypokalemia or hyperkalemia? Obstruction, which electrolyte imbalance will aggravate the intestinal obstruction?
So,
hypo or hyper? Okay, ठीक है.
Hello.
That's all
yes,
from my side. Okay.
Yeah. Hello. Can you hear me, Vaidya?
Yes, ma'am.
Yeah. Anything you read about the rectal enema in interception? It is one of the investigation procedures.
Yes, ma'am.
Yeah.
Ma'am.
Rectal contrast will be quicker call. Tell.
Now we have actually okay.
No, if you otherwise, sir will tell about that one.
Ma'am, I did not read in details, but in this patient, it was normal rectal examination.
Okay.
It was normal. What was normal that?
Sir, there was no proliferation. There was no proliferation of the rectal mucosa.
Proliferation you will find.
Prolapse on this one.
Okay, okay. From my side, it's over.
Okay, it's over, sir. Over.
Okay. Thank you so much.
Abhishek.
You may leave the call. Okay, Shivani, you're there? Hello.
Yes. Hello.
Sir and ma'am, allow me to introduce you to our director and founder, Ms. Shivani Gola. She's a final year student from MGM Medical College, Mumbai. And she's the director and founder for Clinicase. So she'll
Hello.
go ahead.
Good evening. Good evening, sir. Good evening, ma'am. Thank you so much for coming
Good
on
evening.
board and
Good
judging
evening.
this
Good
case
evening.
presentation competition for International Academy for Medical Students. We are so honored to have you on board, and this was an amazing competition. I loved each and every part of it. I could learn a lot of things from both the professors and even the case presenters, the amount of confidence, and though they were fumbling somewhere here and there, but they were still so confident on camera, and this is being live streamed on YouTube. So it's a really commendable thing that they have with so much of confidence, and they've presented their cases, their case reports. So I hope this was a really good experience for you as well as the case presenters. And thank you so much again for joining us today for International Academy for Medical Students.
Hello,
would you
Shivani.
like to?
Thank you.
Yes. Would you like to give any feedbacks regarding the
Yeah,
convention?
yes, definitely, Shivani. We'll appreciate as a student, you have both of you came together, Abhishek and yourself. It is a very appreciable this one competition from the student side.
Thank you,
Okay,
ma'am.
because first time I'm attending your this one. I think it was started last year.
Yes, it was started last year. We had a group case presentation competition last year called Exquisite. Even that was a national competition. In that, a group of people were presenting a case.
Yeah. Now, only thing, whenever the students will be presenting and all, as you told, the confidence is also very important. At the same time, just one suggestion from my side is a student has to read, because they'll be knowing how many hours prior the cases, how many hours prior
so
the
the cases were brought by them itself. They gave their case reports, they submitted, and then it was selected out of the many case reports that we received.
Okay. Means the presenter and the cases will be known at least some 3-4 days prior to the presenter.
Yes. Their reports were already with them. It's brought by them only. We didn't give them the cases.
Yes. What I want to suggest, they should, whenever they'll present the cases and all, they should read thoroughly. Plus, they should examine the patient. Clinical science, very, very important, because nowadays is a forgotten entity because of imaging era.
Yes, and even because of the pandemic, a lot of, even me being a final year student, I have not really gone to the hospital for the past 1 year. I've been home. And
I know.
Yeah, so there are a lot of limitations, but still we are trying, to get that back. And slowly and steadily, once the pandemic settles, I think so we'll get back to normal and we'll be able to examine the
Yes. Yeah. Okay, thank you. Yeah, yes. What I want to say, you should not forget the clinical medicine. Okay, this is the modern medicine because of imaging, but we are all the clinicians. Okay, we don't know what you are going to become in the future, but we are all clinicians. Till you finish your MBBS, you are a clinical student. Yes or no? So now, because of pandemic, it is an excuse, but still, no, it will help you lots in your future. When you communicate with the patient, when you examine the patient. Okay. Thank you, Shivani.
It's a very important point that you've picked up. This is so important, and it's important for the students also to understand. Before becoming a big surgeon or a big doctor, you have to become a clinician.
Yes.
How you will diagnose it.
Yes. This is basic medicine. Okay. Thank you, Shivani.
Okay. Thank you, ma'am. Thank you, sir.
Okay.
So we can conclude the session. Yes, sir. Please.
Yeah, from my side, the same. What actually, madam told my words only, because whatever she suggested the same thing I would like to suggest you. But yes, because this is the era of technology, though the era of technology, this astuteness of the clinician and the analysis of the keen interest in history taking, and unless you do that, we can't practice as a, expert clinician. No.
Definitely,
We are,
sir.
otherwise, without the, because we are working in the developing country like India, where the all facilities or all, infrastructure is not adequately provided at a national level. So most of the time we rely on our clinical judgment, and that
Definitely.
has to be done with by taking keen interest in history taking, examination, and everything, whatever the examination or whatever the test we should, and they should the students start thinking, they should start thinking rationally. What is the rational? What is the physics? What is the basic science involved? And
Logic
because
behind,
personally,
yeah.
yeah. Personally, I'm more important in this, knowing the very basic science, because unless, what I believe is that unless and until you know the basic or fundamental of that or essence of that subject, you can't develop. So yes, I'm totally agree with the madam, whatever madam has said. Okay, that's all.
Yes, that's why, sir, we came up with this concept of clinic case, that the essence of clinic case is doing case discussion. We do 2 case discussions monthly, and this month we've had this international convention, so that we can put it out there, on spotlight, that clinical case discussion, the importance of history taking, examination. It is so important, and it is the basics of each and every undergraduate student. Every undergraduate
because
student
nowadays that is because of
this.
this technological era, that part is most neglected part, I would say, because even the nowadays what I see is even the faculty have forgotten the reading and even the detailed history taking, because what we do is just download the PPT and just go and read it. That is not the way of medicine teaching. Okay, but whatever the ultimate, how I would like to summarize this session is by saying that you are striving for the noble cause. That is what I would like to put.
I completely agree, sir. I completely agree with ma'am and sir.
I really appreciate your effort.
Thank you so much for all your
and
wise
thank you, madam.
advice.
Thank you so much, Pramna. Even I have learned so many things from madam.
That is so sweet.
Shivani and Abhishek. Shivani and Abhishek. Huh? Both, I'll congratulate you, both of you. Why means you are the this one. You have started this initiation, no? Yes, sir. As sir has told, it's a very noble cause. Yes or no? Oh, wish you all the best, and we're expecting very good clinicians in our futures. Okay.
Yes. Thank you so much, ma'am. Okay. This motivates us a lot to work more.
Thank you. Yes. Thank you.